If we can summarize ACA in a nutshell, it is capitation part 2, and this time it's for real. And the only way hospital systems are going to survive on the margin is through cost reduction, because the heart surgeons, the orthopedic surgeons that are now the stars that administration caters to are going to be the pariahs, because you don't want to put in that expensive appliance, you don't want to put in that pacemaker, because everything's going to be capitated, and the growth of Medicare Advantage is going to far outpace anything that goes through the Obamacare collective. New Mexico has the lowest, we're 50th in commercial insurance. That's almost a death sentence, because as you know, commercial insurance is where you make up for all the financial shortfalls. So we have to be innovative and creative to survive. We're actually you 5 years from now, because some of you, you're at institutions where you had some of your best financial year, where your margin was 5 or 8%. There are Floridas in hospital making 9% margin. They don't care about innovation. They don't care about flow. They don't care. But when ACA comes, and that $700 billion cut in Medicare comes, that's part of Obamacare that most people don't realize, patient flow all of a sudden is going to be critical, and you guys can have incredible political leverage. Chief Medical Informatic Officer at a major university and hospital system in Chicago, and they said that a 0.1 reduction in their average length of stay equal to $14 million to the contribution margin. So this is what patient flow should look like. This is how you help your hospital. This is how your hospital survive. This is our Left Without Being Seen in our hospital downtown where we work. It's embarrassing. At 2009, it was over 10%. And as you can see, as we created capacity and throughput, the average length of stay went down. So you have to think of hospital flow as an integrated process. Right now, at your hospital, your flow is an aftermath of all the individual departments that are siloed. The CFOs on your case, nursing, hospitalists, ultrasound, pharmacy, hey, they say meet this year's budget. And aftermath of all that is your patient flow. What we did was the exact opposite. We had a vision of we need to do patient flow, and we're gonna bust across all departments and budget appropriately. We believe in an integrated process. Everything is geared towards patient flow. Our hospitalist group is geared towards patient flow. It's not geared towards generating RVUs. We don't even care about RVUs. We care about patient flow, because if we don't discharge, the hospital shuts down. We want to standardize everything that's not medical. We want to standardize communication. So we removed the perverse incentive for the hospitals to discharge. We're one of the few programs in the country where our census floats. Hospitals and doctors obsess about their census. We don't have the socialist approach of leveling the census every morning. And this discharge before noon, we think it's not only a fallacy, it's actually a perverse incentive not to discharge. If you're rewarding your doctors to discharge before noon, are you praising someone that went at 11 o'clock this morning when they should have gone at 4 o'clock yesterday? So basically, I realized as a hospitalist, I was rounding the same way I was rounding when I was in private practice. And we had to come up with a process to decrease our average length of stay. So my question is, when you have an issue, do you have a process? Deming basically said that if your institution focuses just on cost, quality will tend to go down in time and your costs will actually go up. If you invest and focus on quality, believe it or not, your costs will go down and your quality will go up. Communication processes that took 30 minutes to sometimes half a day now takes 5 to 10 seconds. And whatever process you go back and implement at home, you have to answer the question, what's in it for me? If your process doesn't alleviate their work, or you don't give them the resources to put in new processes, it's gonna fail. You have to go back to your institution and blow up everything and re-put together. You have to emphasize patient flow. Right now, you're trying to do patient flow in a system that was designed for revenue generation, and there is no revenue generation with the ACA in the next 5 years. You have a lot of hard work ahead of you, but I hope we serve as a model of what you can do in the future. And that's it. Thank you.